Good morning, everybody. Thanks for coming. I know this is not our usual Wednesday morning for grand rounds, but we're fortunate enough to have Dr. Stephen Lyman visiting us today from the Hospital for Special Surgery. Stephen is their Director for Healthcare Outcomes, is that correct? And he's also an editor at the Journal of Bone and Joint Surgery, one of the deputy editors there. He has, I think, somewhere in the vicinity of 300 publications now in primarily orthopedic health outcomes research, and I think everybody knows that we're entering an era where what Stephen has studied is becoming more and more important to our academic mission, our clinical mission, and really our financial mission. It really has all converged now to be something that not only can we no longer ignore, but any modern orthopedic department that wants to survive in this coming era really has to embrace health outcomes research. And so we're looking to Stephen for a little bit of wisdom today, and then hopefully long-term into the future. Thank you.
Thank you for that introduction. Can you hear me okay? I'm going to try to do this without coffee. I haven't done that before. So, good morning. I'm Stephen Lyman. In disclosure, I'm a consultant with the FDA, the Academy, and the Japanese Orthopaedic Association. Then I'm on the editorial board of several orthopedic journals. A little bit of background about me. I finished my PhD at the University of Alabama at Birmingham in 1999. I worked with Jim Andrews at the American Sports Medicine Institute, looking at pitching injuries in children, identifying particular risk factors around how many pitches a child could throw safely, and then Little League Baseball adopted those recommendations subsequently. I was then on staff at the American Sports Medicine Institute for a few years before moving to a think tank in Washington, D.C., and then finally joining Special Surgery in 2002, where I've been ever since. So I'm going to talk about value in healthcare, and then moving really from volume to value, outcomes measurement, and then the future of value measurement. So this looks like a joke, right? This is actually from a government website as to what our healthcare system looks like as far as the government sees it. And down here are hospitals and physicians. That's physicians, that's hospitals. Everything else is payment systems, bureaucracy, everything other than caring for patients. A little scary, obviously. So how do we define value? It's a simple formula. It's quality divided by cost. So the higher the value, even if your costs are fixed, or sorry, the higher your quality, even if your costs are fixed, you're providing better value. But do we have value in healthcare? I'm sure you've seen some of this before, so I'll go through this quickly. 2014, an estimated $3 trillion spent on healthcare in the US, 17.5% of GDP. Current government estimates are that nearly 20% of GDP by 2022. It's not that far away. Why do we care? It's not a productive use of resources. We'd rather be spending our GDP on something else. And then this spending trend obviously is unsustainable. This is healthcare spending trends across 7 major countries. I'm sure that the creator of this slide cherry-picked a little bit, but we're up here, several other developed countries down here. They're all spending 9 to 12% of GDP. We're spending 17. In those countries, of those listed, we actually have the lowest life expectancy. So we're not necessarily getting a lot of value for all the money that we're spending. Generally, the more you spend per capita, the more value you get, but we're an outlier, both because we spend more and we don't get as good of outcomes as some other places. Obviously, this is multifactorial. It's not just about healthcare delivery. We have lots of reasons why people may be sicker or not living as long here. But spending varies widely across the country. You have very low spending areas, and then you have very high spending areas. And yet outcomes don't seem to change much. This is all 50 states plotted on a measure of general health. You can see how much you spend makes no difference in what your score is. So it really doesn't seem to make much of a difference how much we spend on healthcare. I think part of why this is, though, is that we're practicing what I call flat of the curve medicine. So it might be cost effective to go from here to here, or from here to here. This is quality of life going up and your costs here. But it might not be worth spending this additional dollars to go over here. And that's the flat of the curve. That's where I think we're spending a lot of our healthcare dollars. An example from orthopedics, this is actually from the literature, from conservative spine management to fusion, I believe this is for low back pain, costs about $33,000 per quality, so that's quality adjusted life years. It's a measurement from cost effectiveness analysis, that's considered cost effectiveness. Then moving from fusion to laminectomy and non-instrumented fusion, about $80,000. That's still considered value or cost effective. However, going from this to laminectomy and instrumented fusion, $4.4 million in quality adjusted life years. That's not good value, right? So this is an example of flat of the care medicine. Maybe we don't need to go to this level when this may be sufficient. So in general, we lack value. We have high costs with average to below average outcomes in many areas. We're really playing at the margins. We're not necessarily spending our dollars as efficiently as it could. And now what's happened is now payers are beginning to focus on value-based purchasing, bundled payments, alternative payment structures. It's no longer a fee-for-service world, or it's rapidly moving away from that. And we, as an orthopedic community, we need to be on top of this. So who defines value in orthopedics? Right now we have lots of other organizations telling us, both journalists and then the government, trying to define value, but I really think that we as an orthopedic community need to be the ones who are doing this. We understand the nuances of what we're doing and what actually is valuable care, but I think we also need to be honest about that. So this is actually the single biggest expense in Medicare. The most Medicare dollars for a single intervention is for total knee replacement. So I'm going to spend a lot of time today talking about the total knee replacement. It's objectively a cost-effective procedure, so there isn't necessarily pushback about doing less of them, but it's just doing them efficiently and making sure that we have value. So I'm sure all of you are familiar with the concept of the volume outcomes relationship. This was first posited in cardiac surgery and as far back as 1979. It's been shown that there's been shown to be strong high volume relationship between how many cases you do and your patient outcomes across a number of specialties, cardiac, bariatric surgery, and of course orthopedics, which I'll talk to. But we have a problem with how we define value in orthopedics. We really have arbitrary threshold assignments. If you go to the literature and you look through the papers, what's high volume, what's low volume, every paper is using a different cut point, a different data set, so we don't really have a great way of knowing that. You can do it arbitrarily, so less than 12, I guess, is less, let's say less than 12 a year, that's less than 1 a month. That's easy for us to wrap our heads around, but is that the right number? It may not be, even if it's intuitive. And then there's quantile analysis using tertiles or quartiles, where you're basically breaking down the distribution of your data. And then recently, area under the curve analysis was proposed, and I'm going to talk a little bit more about this. So getting into the total knee volume literature, various papers, this is a systematic review, various papers have defined low volume as less than 3 to less than 52 cases a year. And then high from less than or more than 5 to more than 70. You immediately see the problem here in trying to define what's high volume for total knee replacement. Another problem with these volume definitions is we lose information, and because we've taken a continuous variable, which is volume, and broken it into categories, which can be problematic. And then regulatory applications. So the Leapfrog group with evidence-based hospital referral has already begun to take volume literature and apply it to reimbursement and tie it to preferred centers for care. And they did this for Cabbage, where they said a hospital volume of 450 a year, a surgeon volume of 90 a year is where they would recommend people going. So there's a problem with that. So this is Cabbage procedures. If we cut it at 450, all of these providers are out of network if you're using this as a network payment structure or as a preferred referral. So then that limits patients to these providers. But does it really matter? In fact, this study showed that it didn't matter if you cut it at 225 or at 450, patients were going to get the same value from their care. They were going to have the same quality outcomes. So we decided to study this in total knee replacement. We decided to try to change how we define value. We used New York State Sparks database from 97 to 2009, primary total knees, New York State residents, and then we looked at 2-year revisions and 90-day complications to define our volume cut points. I'll get into what SSLR is in a second. And then we did multivariable analysis for revisions, complications, and mortality. And then we compared our method to area under the curve and then the quantile method, which has been used previously. So this is 2-year revision rates by surgeon volume. You can see a pretty strong relationship. It gets noisy out here because you end up with a smaller number of surgeons. The these were the complications that we considered. I'm not going to read them all to you, but these are the usual suspects from CMS. And then, so this is the complication rate. Before I showed you the revision rate, this is the complication rate. It pretty much mirrors the revision rate by volume, pretty strong. So we used 3 approaches: the quantile, where we broke it into groups. I think we used tertiles. Area under the curve analysis using ROC curves. And then the stratum-specific likelihood ratio, also using ROC curves, but allows us to identify multiple cut points, where AUC only allows you to identify one. So traditionally, AUC curves are used in cost-benefit analysis, in diagnostic decision-making. Our test result here is surgeon volume. Using that as the diagnostic test, and our disease status is revision. So this is the area under the curve. Everything above this line, which would mean no diagnostic predictability, this is the area under the curve. So if you cut it at 25 cases a year, you might have that much area under the curve, 35, 45, 55, and that's where you would optimize your area under the curve, because you would have maximized your predictability of volume as a measure of quality. So if you look at the 2-year revision rate, based on the volume threshold, this is how the area under the curve moves. It's still only around 50% or 0.5. We want to be up around 0.8 for a real diagnostic test, but it maxes out around 55 a year. But we discovered this paper from 1993 using stratum-specific likelihood ratios, which we thought would be useful because it allows us to retain additional information and identify different cut points. So this is how this would work. So first you'd identify one cut point and then another, and then you're capturing much more of the area under the curve using this methodology. And the formula is pretty simple. It's the abnormal, meaning revisions, over the total revisions over the normals the stratum, the revisions within that strata of volume over the total number of revisions, and then those without revision within that strata over the total, the total number of cases. And so this is how it would work. This is surgeons who had done 0 cases previously in the past 12 months. This is surgeons who had done 1 case, 2 cases, 3 cases, and then this is their number of revisions and the likelihood of having a revision. So you can see it kind of bounces around a little bit because you're looking at individual volumes, right? This is looking at a continuous variable. But then you can start to collapse them because you see that these are similar and the confidence intervals overlap. And then you reach a point where the confidence intervals don't overlap, and that's a point where you would decide that you want to make a cut. And that would identify a strata. And we did that, and we identified 3 stratas using 2-year revision, 0 to 12, 13 to 59, and 60 plus. And you can see the likelihood ratio is decreasing, so it's fitting our idea, our concept. The more you do, the better you are. We also did this for the AUC and the tertiles to break out the categories. And then we went through the same process for complications and found 4 categories, which are pretty close to these, but then we have this higher category up here. This is for surgeon volume. So we end up with, these are the different cut points here across the bottom, shaded to see how they measure up. And then we started to do analysis of these cut points to see whether or not they held after risk adjustment. This is survival. You can see high volume surgeons had about 2% revision rate. The lowest volume had about 3.3, and statistically significant differences. And then this is where the cut points were for complication. So then we did a multivariable analysis adjusting for age, sex, indication, race, hospital volume, insurance type, comorbidities, and then surgeon experience being years in practice. And what we find is these are hazard ratios. This is our lowest volume category, and our reference is above 60. And you can see we have better discrimination in our hazard ratios using the SSLR-derived methods than the other ways. We get larger hazard ratios because we've optimized where that cut point should be. Same thing for complications. We have very nice discrimination here, and it doesn't work quite as well when you use the more traditional methods. This is mortality, which we didn't base cut points on this, but we did analyze it. You can see again a pretty strong relationship between mortality and surgeon volume. And then when we applied the revision or the complication SSLRs, we again saw discrimination for mortality. It also works for hospitals. So we applied the same methodology to hospitals and identified low, medium, and high volume hospitals. And what's interesting is, when you look at complication risk, surgeon volume and hospital volume, it's pretty clear that higher volume surgeons in higher volume hospitals have the best outcomes, but it's not independent. High volume surgeons in low volume hospitals don't fare that well. So really it's an interaction between hospital volume and surgeon volume, and we're now beginning to try to disarticulate the two. So one strategy that's been proposed for a long time is regionalization of care. This is really sort of the idea behind Leapfrog, which is where you try to get patients preferentially referred to centers that do high volumes. So you can move people from local low volume hospitals to regional high volume hospitals. I'm at special surgery, so I'm sure that sounds self-serving. However, this is animated, but this is a conceptual framework for essentially a cost-effectiveness analysis where you have your knee replacement, then you either don't have a complication or you do, it then fails or it doesn't, and then you have some post-revision status and you may bounce back and forth between revision and post-revision. Let's see if I can get this to work, just so you can watch a little bit. Oh, here they come. So we're not going to watch all of them, there's several. So anyhow, so what we found when we studied our volume categories by cost is we actually found that the highest lifetime costs were associated with the lowest volume hospitals, and the lowest lifetime costs were with the high volume hospitals. And this is the lifetime benefits. This is the QALY's gain, quality adjusted life years gain. So you see we have lower costs and greater benefits. So those of you familiar with cost effectiveness analysis, very high volume dominated all other categories because it was both lower cost and higher quality. So if we applied this nationally to Medicare, if we moved everybody out of the low volume centers, it would save Medicare about $1 billion a year. If we moved everybody out of low and medium volume, it's about $2.5 billion. And then if we moved everybody to the very high volume category, it would be about $4 billion a year in Medicare savings. That's about 5% of their total spend on total knee replacements. That's just from the cost savings associated with complications, readmissions, and revisions. Of course, there's a problem with that is we can't necessarily do this. We're not going to achieve moving everyone out of those volume categories. We're not going to be closing down the orthopedic departments in small hospitals, those sorts of things. But this is a cost containment strategy. If we can start to get patients to preferentially refer to higher volume centers where they provide better care, you're going to reduce costs for the system. So why do higher volume hospitals deliver better care? Is it appropriate patient selection? Is it appropriate use of technology? Is it the right surgery with the right device for the right patient at the right time? That may be what's happening. It may be around decision making, but there's probably also some technical skill involved. And then another question is, can we differentiate preoperative or early postoperative predictors for what happens to patients downstream and then intervene early to try to prevent further problems with the patients? This is sort of future efforts around this research. So I want to take a break for a second from total knee replacement and talk to you about hip arthroscopy. Do we have any hip arthroscopy surgeons in the room? There's one. So arthroscopic treatment of FAI has increased 800% in the last decade in New York State. And New York State's a low arthroscopy state. New York State doesn't do a whole lot of arthroscopy relative to other parts of the country. It's increased 800% with no high quality prospective evidence for safety or effectiveness. That doesn't mean we shouldn't be doing it, but we need to be aware of this and think very carefully about it. So we did the same thing, but we applied the SSLR methodology not to annual volume, but to the learning curve. How many cases do you have to do hip arthroscopy safely? So current clinical consensus across a wide body of literature is you need to do 30 cases before you're competent. Our research showed 97 cases is where you begin to be competent, and about 500 cases is where you've reached a point where your patients don't often have revisions. And part of that is driven by surgical decision making, because if you look at those 4 categories of volume by age, the one that's skewing younger is your highest volume category. So your highest volume surgeons are preferentially treating younger patients with hip arthroscopy, likely because they've found that it works in those patients, whereas the lower volume groups still sort of trend toward older patients. And this is also evidenced by whether or not the patient has a diagnosis of OA at the time of the hip arthroscopy. 1.3% of high-volume surgeons will have done hip arthroscopy on a patient with OA, 17% of low-volume surgeons. So very different indications, both on age and OA status for doing hip arthroscopy. I think the literature is pretty clear. You want to do it for acute injuries, not trying to prevent OA or to treat the OA, right? We learned that from knee arthroscopy. We learned that from shoulder arthroscopy. Now we're seeing that for hip arthroscopy. So this is that learning curve effect. So if you ignore age and OA, this is the risk of revision surgery within 5 years. 4.5-fold risk of having a revision within 5 years for the lowest to the highest. However, once you include age and OA, it drops to 3.2-fold. That's still a huge difference. And actually, there's not much discrimination with these cut points once you adjust for age, sex, and other covariates compared to this. So really, you need to do about 500 cases in your career before your patients are going to have a lower risk of revision. And this is what I'm calling the indication effect. This is once you take age and age and OA into account, about 27% of the difference between the 500s and the lowest group is due to that indication choice, just based on age and OA. And of course, there are other factors in determining whether or not you want to do the arthroscopy. So now I'm going to change gears again. I'm finished talking about volume. Now I'm going to talk about patient-reported outcomes, or PROs or PROMs. Right now, it's our gold standard in orthopedics. When you're doing elective orthopedic surgery, the best way to know how a patient's doing is to ask them. Now, two of the most popular hip and knee surveys were the Harris Hip Score and the Knee Society Score. What's the problem with those? They're largely surgeon-derived. And I'm sure you guys are great surgeons, but you also have a bias to have great results for your patients, right? Of course, they're doing fine. I operated on them, right? It's confirmation bias. I made the right decision. So asking the patients themselves is actually a better way of doing that, even though patients have all sorts of issues as well. And so we're trying to do some work around taking that variability in patient health literacy and all sorts of things like that out of the equation in these PROMs. So this is how the National Quality Forum defines a PROM. Any report of the status of a patient's health that comes directly from the patient without interpretation of the patient's response by a clinician or anyone else. So it's just based on the patient's own perception of their health and without any outside influence. And CMS has taken notice. Originally, we had process measures where they were measuring things like % vaccinated and that sort of thing. Almost none of those measures applied to orthopedic surgery, especially elective orthopedic surgery. Then they moved to safety measures where they're looking at things like infection rates, readmission rates, that sort of thing. And as of July, they've announced the plan, last July, to make PROs part of the new bundled payment for hip and knee replacement, which I'm sure you're aware. And that's really measuring outcomes. That's measuring patient function, pain, quality of life. So the best validated currently for hip and knee replacement are the HOOS and the COOS, but they're 42 and 40 questions respectively. There will be an estimated 500,000 total joint replacements done for Medicare patients over the next year. So those are probably too long to administer in your clinic for patients that are considering joint replacement. So we wanted a shorter survey. And PROMs capture, even from established registries that are dedicated to doing this, they really struggle with patient follow-up. They're getting follow-up on rates of 40% or less unless they have heavy investment in increasing those follow-up rates, which most clinical practices aren't going to have. So we want to increase adherence by reducing responder burden and focus on items most relevant to joint replacement patients. So we wanted to make a joint-specific, shorter PROM that maintains validity and utility for outcomes assessment. So there is a shorter form already. There was the COOS-PS and the HOOS-PS. These are physical function short forms, which is a problem because, well, I'll get to why, but these got the COOS down to 7 questions and HOOS down to 5. But these are physical function only, and they were validated in more sports populations, early OA, pre-OA, ACL, those kinds of groups. And here's the problem is when we looked at our own registry, the questions in blue, the items in blue are actually items that aren't necessarily relevant to a hip or knee replacement patient. For example, pre-op total hip patients found that socks and stockings and bending to the floor are more difficult than TKA patients, and yet those questions end up in the TKA, or in the knee survey. And then a lot of the items were skipped by hip and knee replacement eligible patients because they just weren't relevant to their daily lives. Kneeling, squatting, running, these aren't necessarily things that people who are ready for a joint replacement are doing. So we decided to develop a new short form for joint replacement specifically. So we wanted to identify the items that are most relevant to patients' recovery. We did this quantitatively by looking at what we would call preoperative difficulty using our registry, and then also qualitatively, the most relevant, we actually did a survey of patients to ask them which of these questions are most relevant to your current state of health, of hip or knee health. And then we developed a reduced questionnaire. This is the process we went through. The rash analysis is sort of the secret sauce here. I won't go through all of this, but essentially we were trying to identify a reduced number of questions from the HOOS and KOOS that would allow for reliable measurement of the current state of hip and knee health of the patients. These are our patient populations. We did the original work in our HSS cohort registry, and then we did external validation with the FORCE registry out of UMass. And we looked at internal consistency, unidimensionality, construct validity, floor and ceiling effects, and responsiveness. And then we compared them to the current HOOS and KOOS domains, the WOMAC domains, and then also the previously validated short form. And so this is what we ended up with. This is, we excluded the quality of life a priori because those questions are phrased significantly differently than other items on the surveys. And then there were some that were redundant. They'd ask the same question about pain and about function, and we wanted to only ask the question one time. So we'd only include the one that was more difficult and more relevant for the patients. And then one was deemed irrelevant. The patients just didn't think the item mattered. And 30 items were assessed with the rash model, and we ended up with these 12 items after we went through a bootstrapping process. And then we went through one more pass, and we ended up with those in black are the items that were retained for the HOOS Junior. 6 items. We did remove one other because it had high missingness. And then we did have high internal consistency. So it was measuring a single domain of health. And then this is what, this personal item map actually ranks the items from most difficult to least difficult. And so most difficult was number 2, which was walking on an uneven surface. And the least difficult was I think that's number 6 actually. Number 6, which is sitting. So that makes sense. Walking on an uneven surface versus sitting, they're ordered in what makes sense. So the items seem to be working the way they're supposed to. External validity, very high correlations with both pain and activities of daily living, as well as WOMAC function, WOMAC pain, and then finally with the PS, actually with the short forms, really high correlations with the short forms, despite the fact that we were looking at joint replacement patients versus, or that we were looking at joint replacement patients, and those were developed for physical function only. And also high responsiveness. So you want your standardized response mean, I apologize for the small font, to be 0.8 or higher. The juniors actually were as high, if not higher, than almost every other domain that we considered. And I think part of this is because we were removing items that were confusing to patients. We did the same thing for the KOOS. I won't go through the details, but again, high internal consistency. These are the items that were retained. Again, the person item map fits the way it should. This is going up or down stairs, and this is standing. So again, we have very good discrimination in that way. Again, very high correlations with pain and function, and high standardized response means, but not as high as we'd expect. The total hips are going to have a bit better response than the total knees because we have that 15 to 20% of knees that have residual pain or stiffness or difficulty. So one of the big concerns as we were talking to both CMS and the specialty societies about this new instrument is how about discriminating between pain and function? In the original conversations that AUKUS and AAOS were having with CMS was that we needed to be able to discriminate between the two. But patients don't. So this is the HOOS pain and function surveys, very high correlations between the two, both preoperatively, and then this is the change score between pre-op and post. And then the junior score, very, very high correlations with pain, and then also very, very high correlations with function. So this single survey with a single score is actually measuring both pain and function simultaneously. And I think that that's largely because that's how patients feel. Their function's limited by their pain, not necessarily by other things. It's a little more nuanced with the KOOS. We don't have as strong a correlations. Well, we have strong correlations, but the response isn't quite as strong Again, because you have the added issue of stiffness. There is a stiffness item in the junior, but I think some patients have stiffness, some patients don't, so that kind of muddies the waters. So those were recently published in Core. Now, they were published in January 2016, but they actually ended up in the Federal Register in November of 2015. So before they were published, they were already part of the new CMS bundle because the orthopedic community needed a short survey to administer to patients rather than the full 40-item surveys, which were the only other option available. So those are our questions again. So finally, I want to talk a little bit about the future of outcomes measurement. And so we've undertaken a mobile technology assessment looking at people's smartphones and whether or not we can track their recovery after surgery. So in this pilot study, we load a mobile app onto the patient phones. These are hip and knee patients from 12 surgeon offices, and we follow those patients for 6 to 12 months after surgery. So far, we have 122 post-ops. 66 have reached 6 months, 105 hips, 79 have reached 6 months. A few patients are dropping out, and that's largely because the app that we've been using has a GPS monitoring function, which drains the battery. And we actually haven't been looking at their GPS measurements, so unfortunately, I think we chose the wrong technology for this pilot assessment. So this is an example of what we get. So this is a total hip replacement, 54-year-old male. This red line is his pain score after surgery. Surgery's here, day 0. The green line is his HOOS quality of life. This is before we developed the juniors. But you can see quality of life increasing, pain decreasing. And this is our estimate of what his preoperative movement was. And then you see it drop off after surgery and then rise over time after surgery. And an unintended consequence of this, the patient says, this is a quote from him at the bottom. We interviewed a lot of our early patients. Mornings I'm stiffer, like transitioning from sitting to standing, so I don't have that normal flexibility yet. But when you see the numbers pop up, it reminds you that despite the aches and pains taking place, there was an improvement. So it's definitely useful from that perspective. So patients found it motivating. If they saw how many steps they had done yesterday and how many they'd done today, they'd go take a walk after dinner if they hadn't exceeded yesterday's step counts. So it's actually become a motivational tool for some of these patients. And then in our preliminary analysis, what's interesting is we've been using cluster analysis, we've been able to identify different clusters of patients and how they respond after surgery and how their movements are. So this green line here is flat, which essentially they had no increase in their step counts. There's a cluster of patients that do that. There's a cluster that move very, very rapidly, start to increase their step counts, and then there's some that have a gradual increase. That's for hips. This is what we'd expect for hips, right? Hips can start moving very quickly after surgery. They get up and about, they feel a lot better. Knees, it takes a little bit longer, where all 3 clusters are essentially not very active. So this is a proportion of average preoperative steps. So once you exceed 1, that means that you've exceeded your preoperative average. That doesn't happen until about day 30, even in the most optimistic knee patients. This is only out to 40 days. Our further analysis obviously will be able to do this out to 6 months or a year and identify these clusters. Then it'll be interesting to go into these clusters and see why. So I suspect some of these here in the green, some of them aren't doing well. I think some are the little old lady who needs 3,000 steps to get to the grocery store in her friend's house every day. And after surgery, she's doing that without pain, but she's still going to the grocery store in her friend's house, right? So she doesn't need to walk more steps, so she's not walking more steps, but she's doing it hopefully without pain. So there's further work obviously to be done there. So our next steps for this is we just finished enrollment. We've decided to move away from the mobile app. A lot of patients don't really like carrying their phones. They don't like being tied to their phones, especially in this age cohort. But in September, we'll finish up our follow-up out to 6 months. And right now, we're assessing technology vendors for a partnership in having a branded app and a wearable device. Are you guys familiar with this device? Seattle's a tech city, right? So this is called a Misfit. The Misfit, what I like about the Misfit is, it runs on a watch battery, so you don't have to rely on your 70-year-old total knee replacement patient to charge it with a USB charger. And second, you can wear it any number of different ways. It's got a little metal clip, so you can put it on your belt, or you can wear it as a watch, as a pendant, that sort of thing. I actually carry mine in my pocket, just like a coin. It's just a little silver disc here, if you take any of the other accessories off of it. And you just sync it with your phone. and it gives you all sorts of information about your movements. So nice technology. Okay, so wrapping up, the future of value in orthopedics, alternative payment models will continue to expand. That's not going to change. We can't turn back the clock and go back to a fee-for-service model without any accountability for outcomes. And I think what's going to happen within the next 5 years is all those outcomes that CMS is going to start to collect this year, those are going to start being publicly reported. So patients are going to have access to, right now they have access to things like infection rates and readmission rates, mortality, that sort of thing. Soon they're going to have functional outcome measurements. So we have to make sure there's the right functional outcome measurements that are being captured. And then we really need an appropriate risk adjustment methodology. And nobody seems to have a good handle on this. The most commonly used risk adjustment methodologies were developed in the internal medicine population, not in elective orthopedics. So I think we need to develop a really strong risk adjustment methodology. It's something I want to tackle over the next couple of years. Orthopedics is becoming data-driven. We now have direct measurement of patient function, or the technology available to do that. I think that risk adjustment, I'd like to do that through data mining, because I think when you use an Adelphi method and you ask a bunch of clinicians for their opinions about what they think is important for risk adjustment, they might get the big ones right. You know, it's going to be diabetes, it's going to be obesity, it's going to be age. But what about rare conditions? What are those rare diseases that maybe you'll only see once in your career, but it actually makes a big difference for patient outcomes? On a population level, those actually might matter. So I think a data mining tool using some of these large administrative databases we have is a good way to identify those rare comorbidities that actually make a big difference in outcomes. And I think all of this is going to lead to improved surgical decision-making and patient outcomes, so I think everyone will win if we do this right. So I think that's all I have.
That was great.
Thank you. I guess I talk faster without coffee.
Questions?
Yes.
Thank you very much. I enjoyed that greatly, and I think it's terrific work. If one stands back and looks at two big mega trends, on one side is the collection of information like this, which directly increases our ability to help patients and know what we're doing. And on the other mega trend is the data collection burden, the measurement burden. And both of these are increasing simultaneously. And if I step back and look at it, the trend is for less measurement. IHI, Institute for Health Improvement, said that we should cut down the amount of things we measure by 50% in the next year. That way gives more time for physician-patient interaction. And in the New England Journal of Medicine in the last month, there was an article that said, editorial perspective that said that we have to stop doing all this. We should have small bundles of patient reported outcomes used internationally. No more than 20 questions to cover all that's wrong with us. So how do you, being right in the midst of this field, how could you comment on these, where these two trends, which seem to be in conflict with one another, are going, and what the future looks like?
Yeah, so if I had a crystal ball,
yeah,
which I don't. Actually, so in developing the Huson Coos Jr., I imagine that as being an interim step, because we have now PROMISE with the computer adaptive testing, which NIH developed. We haven't validated PROMISE for joint replacements or for other like sports conditions, but once we do, that's going to reduce the number of questions substantially and probably make the juniors obsolete. I think static surveys that were traditionally administered on paper are going to go away pretty soon. I think we'll still need to measure things like pain and satisfaction, things that only the patient can tell us about. I think functional assessment we're going to be able to do passively. We're not even going to need to talk to anybody to measure function down the road with the mobility technology that we have. All of us that carry smartphones every day, we're being tracked, right? All that information is available. The healthcare system needs to figure out how to leverage that information in an ethical way to actually be able to do this to monitor patients. I think that's really where things are going to be going. When I talked to Jay Lieberman, the president at the time of AUKUS, he wanted 20 questions. That's all he wanted. So PROMISE Global 10 is 10 questions, and then the Huson Coos Jr. is 6 or 7. We're under 20. You have a few other questions for smoking status or things like that. So I think 20 is a good number. I don't think we're going to get to 0 in the short term, but I think we may get there eventually as these technologies improve. I mean, there are now, some of these wearables now can measure your caloric burn, and they can just through your sweat output and that sort of thing. Like there's pretty amazing things that you can just wear and don't even think about it. And that as long as there's a way to get that information from the patient to the provider, then I think there's a lot of opportunity for using that information to measure outcomes without additional burden. In fact, potentially less burden on the provider once the IT infrastructure is in place.
Thanks for that talk. Thanks for coming. In terms of I'm really interested in the topic of value. We have a lot of push and reimbursement tied to that, but I have found a lot of difficulty in pain getting good denominator information. You know, what the cost is kind of measured in so many different ways. So my question was, do you have any insight as to you know, the optimal ways to access the cost information from a hospital system or a database, and also if you have the cost metrics that you think are the most appropriate ones to bundle into that denominator?
That's a great question, and I would say welcome to my world. Getting cost data is nearly impossible from a hospital. A lot of the contracts that the device companies especially have with hospitals are it's on a need-to-know basis. So only the people within the hospital who have to know what that implant costs actually have access to that information, and we're prohibited by contract in sharing that information even with other people in the hospital, let alone actually trying to do research out of it. So it remains a very, very difficult piece of the puzzle to measure cost. The best we have right now are really the cost to charge ratios for Medicare. But each hospital reports those on their own. They decide what their cost to charge ratio is, and that's what they tell Medicare. So a full service hospital like here versus a specialty hospital like HSS are going to have very different cost to charge ratios because of the nature of the patient populations we care for. And you don't necessarily want to apply a general hospital cost to charge ratio to total knee replacements when that's 5% of the inpatient burden. So it's a great question. I don't have an easy answer. But I think at some point that cost transparency is going to have to come through.
Yeah, I've become interested in the cost or per quality adjusted light year for regional anesthesia. And I was wondering, do you have some baseline of how much health-related quality of life is related to pain? And what baseline you would use for a value quality adjusted life year value generally in the United States now?
Right. Very good question. I don't necessarily know of the pain literature is just a whole area beyond orthopedics, right? So I think that's a great question. I'm not familiar with the pain literature in that area. I tend to think of cost per quality rather than how many quality adjusted life years, because that's really dependent on how many years you have left, right? If you're talking end of life care, palliative care, you're trying to keep somebody comfortable, they might be thrilled with half a quality adjusted life year. But you're talking about a young patient undergoing an ACL reconstruction, they want 50 more years, you know? So, but as far as the cost per quality, the usual standards are $50,000 or $100,000 per quality adjusted life year. That's really considered cost effective. So that's the best answer I could give you on that front. Obviously lower cost per quality is better.
That was great. Thanks so much for coming.
Thank you.
I'm wondering, when is the best time to collect this outcomes data? Is it least unbiased if the patient's sitting in the doctor's office with an iPad before the appointment, or in the office where they're trying to look good for their doctor, or at home at the kitchen table with a cup of coffee when they've just woken up and they've gotten an email? And what's the least unbiased time to collect the data?
I mean, we've all heard of white coat hypertension, right? I think sitting in the doctor's office is not a great place to administer that because of the patient anxiety at the time. You know, we have some of our registries, unfortunately, is the way that our hospital's organized. Some of our patients are consented into the registry in the holding area before surgery. I think that's the absolute worst time to do that, to try to convince somebody to fill out some surveys, and you know, you're about to have your shoulder replaced. Let's ask you a few questions. So I do think it's a cup of coffee at home when you get the email. So I think a really electronic measurement, you know, if you have patient email, or if they're willing to use some sort of mobile technology, you know, there are now apps that will allow you to capture surveys from patients. So if you made that part of your suite of care, where here's our UW Orthopaedics app, you load this, you know, and then you can administer surveys that way, and it's another communication tool. But I do think that sort of in the comfort of their own home is probably the most unbiased place to get the outcome surveys.
Okay, we have coffee that's arrived.
Great.
And I suspect people probably have lots more things they'd like to chat with you about. So, thank you.
Great, thank you.